Hi, my name is Connie Planis and you're watching the video on the methods of occlusion that we utilise in managing patients diagnosed with amblyopia. In this video, we'll discuss the various treatment options that we have in managing patients with amblyopia, and in a subsequent video, we'll discuss the regimes we prescribe and specifically the amounts of occlusion that we prescribe to patients. Now, before we discuss the options for occlusion, I want to just bring your attention back to the timing of amblyopia treatment. When can we manage amblyopia and reverse any reduction in visual acuity? Well, by now you're well aware of the critical period and when amblyopia can develop. Amblyopia can develop from about birth to approximately around 7 to 8 or 9 years of age. The literature is variable in relation to the endpoint of that critical period, but consensus between clinicians is that it is around that period, 7 to 9 years of age. So it's during this period that we can also reverse amblyopia and improve visual acuity. However, more recent studies by PEDI, which is the Pediatric Eye Disease Investigator Group, has suggested that you can actually treat children beyond the age of 9 years of age. So if, for instance, a patient at the age of 11 presents to your clinic with amblyopia and hasn't been managed in the past for amblyopia, then it is worthwhile attempting to prescribe occlusion in these patients, even though our previous understanding was that treatment was only successful during the critical period. Despite this, it's important to understand that the earlier you treat amblyopia, the more successful you'll be at reversing the reduction in visual acuity. If we have a look at this graph here that I've given you, we have here on the vertical scale success of treatment, and here we have the age of the patient. And if we imagine that this is 0 age or birth, and we go along the scale of age, and towards here we have the end of the critical period, 8, 9 and beyond. And what we see is when amblyopia is treated early on, you have far more success as compared to when you approach the end point of the critical period. This graph also relates to the development of amblyopia. Amblyopia is far more denser when it develops at an early age, around birth in the first year of life, as compared to when you develop amblyopia, say, at the age of 4 or 5. It will be milder in form and easier to treat. So they go hand in hand. The more cortical plasticity we have, the more easy it is for amblyopia to develop and to develop densely. And it's also better that we treat these patients as early as possible in order to achieve the best outcomes, because the more we wait, the more the amblyopia develops and the harder it is to improve visual acuity in these patients. One other point I want to make before moving on is if you treat a patient beyond the critical period, so say at the age of 10 or 11 or 12, then you run the risk of anti-suppression. So if your patient has central suppression or a peripheral suppression from strabismus, so we have, say for instance, a suppression scotoma between CIP and fovea, occlusion in and of itself can cause anti-suppression. Now, in the presence of strabismus, this is a problem because the suppression scotoma is eliminating diplopia. So should you inadvertently anti-suppress the patient because you're trying to improve visual acuity, you can give your patient intractable diplopia. In your younger child, a child within the critical period, so let's say a 2 or 3 year old, occlusion does not anti-suppress the patient. And it's because you're in a period of high cortical plasticity. So the sensory adaptation of suppression is held and maintained during that time because suppression will continually occur in order to rid of diplopia. However, in your older child, sensory adaptations don't occur. Suppression can't occur in an adult or in an older child or teenager, and therefore that cycle has been broken, whereby occlusion will now lead to anti-suppression and diplopia. So what is the aim of amblyopia treatment? Well, the ultimate aim is achieving equal visual acuity. We know in most instances patients have unilateral amblyopia and that they'll have 2 lines difference or more. And what you want to do is improve the visual acuity of the amblyopic eye so that it is equal to that of the sound eye. However, in some instances, it is very difficult to achieve equal vision. Where you have a patient who's not responding well to treatment, or you're having extreme issues regarding compliance, then at minimum, you should try and achieve 6/12 visual acuity in the amblyopic eye. And the reason we aim for 6/12 vision is because it's what's considered to be functional visual acuity. It is what you require in order to obtain a driver's license, as an example. Now, a patient can have a driver's license with visual acuity poor in one eye. However, should something happen to that patient's good eye and they were left with only the amblyopic eye, you want it to be at least 6/12 so they can be independent, drive a car and have that functional visual acuity when they're adults. The other thing we want to do with our amblyopia treatment is maintain any successful improvement in visual acuity up to the end of the critical period. So as an example, if you're managing a patient at the age of 4 and you successfully treat the amblyopia and the patient has relatively equal vision, then you need to monitor that patient until the end of the critical period, generally to the age of 9 or 10, and ensure that they maintain that equal vision up to that age. You don't discharge your patients once they've achieved equal vision. And the reason is that amblyopia can recur, particularly if there is an amblyogenic condition present. So as an example, if you have a strabismic amblyo who has surgery for their left esotropia and post-operatively they have a small angle left esotropia but cosmetically looks good and the amblyopia has been reversed, if that child is 4 years of age or 5 years of age, the fact that there is still a residual esotropia post-operatively means that they are still at risk of developing amblyopia. So you need to continue monitoring that child until they reach that critical period. Okay, in managing amblyopia, what we're trying to do is give a competitive advantage to the amblyopic eye so that we can stimulate the development of the visual cortex. Now, we know the reasons for amblyopia, strabismus and refractive error and deprivation. And in all those instances, you can see that there is one eye that's preferred over the other. So let's say we've got an anisometropic patient, one eye is +1 and the other eye is +5. Clearly, there's going to be a preference for the eye with a lower refractive error. And what we need to do as part of treatment is give a competitive advantage to that +5 eye. And the only way we can do that is to occlude the dominant eye or the sound eye. Before we occlude, we must also correct the refractive error. So in the presence of refractive error, if the amount warrants correction, then you would always prescribe the glasses first. And then we proceed to the occlusion component of treatment. Now, occlusion can include patching, where we put a patch on one eye, pharmacological penalisation, where we actually instill drops in an eye, and optical penalisation is where we manipulate the glasses in order to create a competitive advantage for one eye. In terms of occlusion, there are 2 types of occlusion. There is what's considered direct occlusion and inverse or indirect occlusion. Direct occlusion is what we all generally prescribe, and direct occlusion is when you cover the sound eye or you penalise the sound eye and give a competitive advantage to the amblyopic eye. Inverse occlusion is when you actually occlude the amblyopic eye, and the only time that you would consider doing this is when you have eccentric fixation. And even then, it's a second-line treatment. You always try direct occlusion first, and if that fails, then you might consider inverse occlusion. The issue is that the evidence is not strong to suggest that inverse occlusion is successful in patients with eccentric fixation. And it actually suggests that direct occlusion is just as good as inverse occlusion. But in some instances where I've had patients who won't improve with direct and have eccentric fixation, I have trialled inverse occlusion. I can't say that I've been very successful with it, but it is an option that you might want to try should the circumstances warrant it. Okay, so in rare instances, you might consider inverse occlusion, but direct occlusion is the gold standard treatment for all amblyopes, including those with eccentric fixation. There are three methods of occlusion we can also prescribe. There is total occlusion, partial occlusion, which is defocusing, and partial occlusion, which creates form deprivation. Let's go through each of these individually. First of all, we have total occlusion. What this means is that you exclude all light from entering the eye, and therefore there is no form perception. And here we see some examples of patients who are having total occlusion. And so here we have a stick-on eye patch, an ortho pad. Here we have another stick-on patch where the child's put some pictures on there. And here we have some felt occluders which are put on the pair of glasses. But in all instances, there is total occlusion, and even with these felt ones, you can see that there is covering above and to the side to prevent any peaking and to prevent any form perception. And again, here as well, you can see that we have total covering of the eye in order to prevent peaking. Now, moving on to partial occlusion, we can have occlusion that causes form deprivation or defocusing. What we're doing with form deprivation is that we're reducing the form, but light is still entering or emitted through the occluded eye. So we can see here as an example, we have a frosted lens where light will still enter, but form perception will be reduced. Here we also have a Bangerta foil, which again actually reduces form perception. And you can get Bangerta foils that increase in form deprivation. So one that causes a mild reduction of visual acuity versus one that causes a greater level of visual acuity reduction. Rather than your patient purchasing a Bangerta filter, you can also just use translucent contact paper, which you can get at a supermarket, and add layers of that on a pair of glasses. This will also allow light to enter, but again, reduce form perception. Moving on to partial occlusion, that is defocusing. Here what we're doing is we're defocusing the retinal image. And generally this is where we might utilise optical penalisation. Say for example, I have a child who has +5 hypermetropia in both eyes. If I don't correct the +5 hypermetropia in the better eye, then what I'm doing is I'm defocusing the image of that eye in order to create a competitive advantage for the amblyopic eye. The other example is if I put atropine in one of the eyes, again what I'm doing is I am creating cycloplegia, which creates the blurred image, and I'm defocusing the image for the purposes of creating a competitive advantage. Now, the distinct difference between total occlusion and partial occlusion is that total occlusion forces the patient to have to use the amblyopic eye. They have no other option but to fix with the amblyopic eye, and visual acuity will improve through that mechanism. Partial occlusion, however, on the other hand, relies on reducing the visual acuity through either form deprivation or defocusing. So the visual acuity will be reduced here, here, and here. Now, in order to be successful, generally what you will require is that the vision of the sound eye being partially occluded being less than that of the amblyopic eye, so that the amblyopic eye becomes the preferred eye to fix with. Now, before we conclude, I just want to come back to pharmacological penalisation and optical penalisation. Let's start off with pharmacological penalisation. In this instance, what we prescribe is atropine. We always prescribe atropine. We don't prescribe cyclopentalate, for instance. And we instill that in the non-amblyopic eye in order to blur the visual acuity in that eye through the cycloplegia. And through this, the amblyopic eye will be the preferred eye to fix with. Now, generally, the atropine will be most successful at near. And this is because it is at near that we use most of our accommodation, and the sarcoplegia, therefore, is preventing that accommodation to occur in order for us to see clearly. So distance is less likely to be affected unless the patient has refractive error that's not corrected and is atropinized at the same time. In that instance, we often get an impact also in the distance. Just to note also that some of your patients may have an allergic reaction to atropine, in which case this then no longer becomes an option for you. So pharmacological penalisation will need to be seized and you'll need to look at other alternatives for treating your patient. The other issue you have is the photophobia and photosensitivity that relates to utilising atropine. And some clinicians are actually very reluctant to prescribe atropine during the summer periods because of the photosensitivity. Okay, let's talk about optical penalisation. In this instance, what we're doing is we're leaving the sound eye, which has refractive error, uncorrected. So if, for example, we have a patient with +4 hypermetropia in both eyes, you would prescribe +4 to the amblyopic eye because you want that eye to have a clear image to be processed by the cortex, but you would plano or not prescribe the +4 for the sound eye because you want to defocus that image and create a competitive advantage for the amblyopic eye. Now, optical penalisation prescribed on its own is often not enough to be utilised as part of amblyopia treatment. It's generally prescribed in combination with pharmacological penalisation. So as we see here, what you would do is plano the right eye and atropinize the right eye, which would be the sound eye, and give full prescription to the amblyopic eye. And here we have a study by Wallace, which shows us the amount of refractive error that can be left uncorrected when combined with pharmacological penalisation and the impact it will have on visual acuity. And we can see here that when hypermetropia is present, the more hypermetropia that's present, the more impact we'll also get in the distance. So if we have a treatment that affects both near and distance, then you have more intense treatment as compared to a treatment that only has an impact at near. Remember I said earlier that atropine generally has an impact at near. So atropine alone may have an intermittent effect on fixation preference, where at near the patient prefers the amblyopic eye, but at far they prefer the sound eye. However, if you combine optical penalisation and pharmacological penalisation, particularly when a patient is hypermetropic, then you increase the likelihood that you will have both distances affected and the patient will prefer the amblyopic eye both at near and distance, which increases the intensity of your treatment. Okay, that brings us to the conclusion of this video. Thank you for watching.